growth hormone is produced. That's how it's done. Now, it sounds really fancy, but I didn't have to do it myself because, IDS ISIS manufactured it for me. We have done these kinds of assays from scratch in this laboratory, but most of the time, the production of those antibodies is prohibitively expensive, usually $50,000 an antibody to get those custom manufactured. Believe it or not, all the labs in Lower Mainland used to have rabbit farms to do this, and that is no more. So this is an ELISA type assay. It allows us to measure both IGF-1 and growth hormone. We just need different sets of antibodies. In acromegaly, we rely primarily on the IGF-1, as mentioned. And it actually is a more difficult assay than growth hormone because IGF-1 it doesn't exist in the plasma all on its lonesome. It has a carrier protein. Lots of proteins don't exist on their own. They have carrier proteins. Testosterone is not a protein, but it does have a carrier protein. So it's a good example. Testosterone doesn't float around on its own in your blood. It floats around on a carrier protein. So what is IGF-1? Well, all proteins are made of the building blocks amino acids, and there are 70 of them in IGF-1. So it's like 70 Lego bricks all stacked together. And it has 3 internal bonds, which I'll show you. It weighs 7,600 grams per mole, if that means anything to you, and it's produced by the liver. And IGF-1 is what creates all of the growth effects that you've experienced having acromegaly. So it was the real culprit. This is the structure of IGF-1 on the left, and you can see why it's considered insulin-like in just kind of a putative sense, because it forms a kind of squirrely ring in 3 internal bonds. But there's more to it than that. There's actually identical amino acid sequence in sections of the 2 molecules. Now, the problem, this diagram is going to confuse people, but I'll try anyway. The problem is this guy, IGF binding protein 3. You can actually use IGF binding protein 3 as a surrogate measure of IGF-1, but that's the carrier protein of IGF-1. So they're always stuck together. And if you imagine it, if you're trying to measure IGF-1 and the antibody can't find its way because it's housed inside the binding protein, it just bounces off the surface. That kind of makes sense. It's hiding inside, so the antibody can't see it, right? Just like when a virus is in a cell, it can't be seen from the outside. It can only be seen from the inside. So the first thing we need to do is get IGF binding protein 3, which is messing everything up, off of IGF-1. And the way that we do that is by acidifying the specimen down to it's kind of the acidity of lemon juice or vinegar, about pH 2 or pH 3 in this case. That will cause the proteins to change shape enough that they don't stick to each other anymore, and then we get them separate from one another. Then what we do is we add a competitive binding agent. What we do is add a whole bunch of IGF-2. And the IGF-2 also sticks to the IGF binding protein, and it gobbles up all the spots on the IGF binding protein. So now we've got it out of the way, and we've got just the IGF-1 floating around free in the tubes. That makes sense? There's just a vacuum cleaner effect. Now we can go ahead and do the straightforward ELISA that we talked about, and we also put the pH, we also take the pH back to normal, the acidity back to normal blood acidity, so that the antibodies will work, because antibodies don't like low pH either. They don't like acidity. Whoops, wrong direction. Now, this is to convey to you that it's really hard to get a normal range for IGF-1. And that's one of the things that's a big pain in the neck for this assay. IGF-1 changes its concentration a lot with age. Down here we have kitties. And what they've done is plotted IGF-1 concentration on the y-axis versus age on the x-axis. So if you were 20 years old, your normal range would be between, say, the 2 red dashed lines, and the average would be in the middle. So everybody who's 20 should have IGF-1 at about between these 2 age categories. So if you look carefully, you realize that the IGF-1 of a 20-year-old in a 60-year-old is not normal. IGF-1 in a 20-year-old is higher because there's just a little bit of growth left over, right? And this is kind of borne out in their muscle mass and et cetera, et cetera. And if you're a kid, if you're a teenager, when you're going through your growth spurt, your IGF-1 is way into the acromegalic range for an adult, but it's totally normal for a kid. kids do, I'm looking at my son, he's 12, his feet are enormous, right? They just get bigger, and they're getting bigger disproportionately to his body. So that's fine as long as that doesn't go on for too long. So in teenagers, very high IGF-1 levels are a bad thing. And I don't know if people are familiar with the numbers they get back from their IGF-1 levels, but if you're under control and you're in the 40 to 60-year-old range, I would expect you to have levels of around 100. That would be typical if you're under control. If you're at the top end of control, you might be in the 200, 250, and if your disease is still going on, you might be a little bit above that. But this is not our normal range, but it was developed by a friend of mine who's now at the Cleveland Clinic, and you can see how many patients they've run. Now these are normals. So how do you get access to 1,500 normal volunteers for your assay? It's a lot of work. So you got to screen them, you got to make sure they don't have any diseases, you got to make sure they don't have diabetes or anything else that could adjust their growth hormone levels, and then you got to get their consent, and then do the analysis, and then do the statistics. This is a multi-$1,000, this is probably a $30,000 undertaking to do this right. So that's why we're heavily reliant on companies. I'm sad about that, but we are. Most of our assays that we do here, most of the interesting assays we've developed in-house. But this one we could do this with an in-house assay, but the challenge would be getting a normal range. So when do we do a growth hormone test? Well, we do, occasionally doctors order growth hormone mistakenly to diagnose IGF-1, and I see a very high growth hormone, and then I phone and I say this isn't normal. And that's what happened 2 weeks ago to another lady who's just seen Dr. Johnson. But we use the growth hormone test to monitor the extent of surgical or medication control in acromegaly. So we usually do this after an oral glucose load, so you get the 75-gram yucky orange drink once a year, twice a year, whatever, in 2 years. I don't know how often you do it. How often do you do it? Once a year?
That was one of my questions. How long or how often should I be asking my endocrinologist or my family practitioner to undergo that test for me?
Well, I mean, I wouldn't be able to answer that question because I don't actually personally manage patients with growth hormone. I'm sure it's in the Canadian growth hormone acromegaly guideline. Those kinds of surveillance techniques are usually yearly. But if there's been absolutely no change in your growth, if your IGF-1 were totally normal, there would be no need to, and you weren't having symptoms. So it's probably playing by ear. I know, probably.
It's like average once a year. But if you're controlled and it's maintained, then probably not.
Yeah.
I don't know the last one I
Oh, well, you're probably under good control.
Yeah.
In Ontario, just speaking from my experience, but initially after my surgery it was every 6 months. And that's kind of in the guidelines that were put out by my endocrinologist, who's kind of the expert in the disease.
Who's your endocrinologist?
Sharini's at.
Okay.
And then once you're stable
I know
for
him.
5 years, I'm sure you do.
Yeah.
I mean, he's.
I pooched some of the slides from my talk to him to put in here.
I won't tell him that. No, I'm sure he'd be very, very honoured that you're using them.
Interestingly enough, I was having my family doctor do my IGF-1 and my growth hormone, but then I found out my endocrinologist was not getting that information.
Oh, that's too bad.
Too bad.
Well, I mean, you know what? Just pursuant to that, myehealth.com, now you would be able to see those kinds of results. Not every kind of test result goes into MyHealth because you don't want people finding out all on their lonesome that they've been diagnosed with cancer or something like that. But results like this do end up on MyHealth. So if you ever want to feel like you want to check your result, bring it to your doctor. I'm not sure that IGF-1 and growth hormone end up there, but I don't really see any reason why they wouldn't. They do, okay. So that's a great service.
Can I ask a question?
Sure thing.
So when you're usually getting your IGF-1 checked without the oral glucose load, should you be fasting or not, or does it
You don't need to fast. It's basically constant all day. It's kind of an average of everything that's happened to your growth hormone level in the last few weeks. So, I mean, it might not be weeks. I'd have to look up how long it kind of maps backwards. But yeah, you don't need to fast for an IGF-1 level. I think some of the hospitals had fasting as a requirement, I think Life Labs had fasting as a requirement.
My endo said he preferred it, but it wasn't necessary, and sometimes the morning the lab is just too busy.
Yeah, it's not necessary.
Good.
You could have it. You could have it anytime you wanted to. You know, sometimes about 10% of the time. Oh, so just back to the growth hormone. If your level goes below 0.5 after the oral glucose load, that's considered to be relatively well controlled. It used to be 1. The threshold used to be 2, and then it was 1, and now it's 0.5. The reason is because the assays are getting better and better and more accurate, and they aren't reacting with anything else except growth hormone. And so when that occurs, the thresholds tend to drop. So the current threshold is 0.5 for the high sensitive and specific assays we run. Sometimes your surgery is too successful and it knocks out your growth hormone entirely, and you actually have low growth hormone. And you may have experienced that you got low thyroid and low adrenal and low growth hormone. If your tumor was very big, there's a big chance that you're going to become what we call pan-hypopituitary, that all of your pituitary hormones are either partially or entirely broken. But fortunately, we can give them back to you. The growth hormone producing tumors tend to be large, so there's a distinct possibility of knocking out some of the other pituitary hormones when you have the surgery. And I mentioned the other things we measure. Well, we always measure prolactin. There's 2 reasons that growth hormone producing tumors could create an elevation in prolactin. One, when you compress that pituitary stalk, you actually cause prolactin to be produced at low levels. But growth hormone producing tumors also often make prolactin because embryologically they come from the same tissue. And that would account for why some folks with what we call somatotroph adenomas or growth hormone producing tumors will have noticed breast milk discharge even if they're male. So that's very distressing for men. Galactorrhea is the name of that. So you call it lactation if it's normal and with a baby, and you call it galactorrhea if it's not associated with a baby.
But can it come out green?
No, if it comes out green, I would think that it might be associated with an infection or with, sometimes some breast tumors can do that. So I wouldn't expect it to look green unless it had, cultured something in there. It would just look like white milky discharge. You can look up on Google Images for galactorrhea, and you can see what it would typically look like. We've talked about the other hormones that might be affected, adrenocorticotropin hormone and cortisol, which are actually life-threatening not to have. Excuse me. And so we always check those. We always check testosterone in men, estradiol and progesterone in women, and the stimulating hormones for those. And of course thyroid hormone, because hypothyroidism causes a lot of fatigue and is kind of crippling if you don't get that. Nothing is perfect. You can get false elevations of both growth hormone and IGF-1, so you can get incorrect diagnoses. And that occurs when, believe it or not, if somebody happens to, let's say, this is one of the ways, if you've had a rabbit farm or if you had rabbits as a kid and you develop antibodies against rabbit, then if those antibodies are floating around, you can connect this what we call the capture antibody and the signal antibody together without the IGF-1 or growth hormone sitting in the middle. And so you create this, what I call like an artificial sandwich or an incorrect sandwich. And that happens, with all the testing we do, we catch one of those, say, once every 2 months, not on these assays, but just in general on all the different assays we do. So you got to keep your eye out for when the results don't match the clinical picture. Nothing from the lab is perfect, and when you get a lab test that doesn't match what's going on clinically, you should always doubt the lab test because, nothing is perfect. And students and residents and doctors tend to believe that the assay is perfect. The other thing we have, occasionally you get sample mishandling, so you might get deterioration of the thing you're measuring. So this sample sat on the shelf. this was a big problem with the old vendor, was what we call lot-to-lot variation, because they manufacture these solutions for us and we get them, but they're doing it in big vats, and not every vat is the same, and you can get changes in the results you get just based on the manufacturing process, which is a bit maddening when you run a lab. So is this the future of IGF-1 testing? I think we're going to dash upstairs. I'm going to show you this instrument. This is what's called a mass spectrometer, and we have 2 of them upstairs. It's a great way of doing testing because it's all in-house manufactured reagents, and that way we don't have the problems with lot-to-lot variation. The challenge for us in doing an IGF-1 assay is not that hard. The challenge is the normal range. So we need a really good comparison with another big lab that had great normal range data that we could adopt, or we'd have to do our own normal range study. So the nice thing about these things, there's no commercial reagents, there's no reliance on the company. We have our own chemistry in-house, so we don't run into lot-to-lot problems, because if we had a bad lot, we just make it again. And companies don't like doing that. If they have a lot that's a little bit close to being outside of spec, they're like, yeah, well, you know, good enough, and cross their fingers, and they do that, actually. So it's a assay we can control, and we've been very successful in diagnosing other diseases with this mass spectrometer, Cushing's syndrome and Conn syndrome, a disease that causes high blood pressure, and it's also used in thyroid disease, although not here. So what about the drugs? Do we measure the drugs? The drugs are very expensive, as you know, if anyone's on pegvisomant or sandostatin. The drugs are pricey, and so one of the things when you're dealing with a pricey drug is should you measure it, and then you can lower or raise the dose appropriate to the levels that you get. Not right at the moment. We don't measure pegvisomant or sandostatin itself. We just measure the effect. So, pegvisomant is a growth hormone receptor blocker. So it's acting like growth hormone, but it's not triggering growth hormone's actions. So it's sort of blocking growth hormone's way to the places that it's supposed to go. So you can't measure growth hormone in those people because it'll be high. It just because it's getting pushed out of the way all the time, it just mounts its concentration higher and higher. So you only measure IGF-1 on people that are on Somavert. So if you've ever wondered why you can't do an oral glucose tolerance test if you're on Somavert, that would be why. And then sandostatin inhibits growth hormone production, so you can do either route for testing, but we don't measure the drugs themselves, although we could in theory. There's no compelling reason to clinically. And that's just reiterating what I just said. We just measure the biochemical effect. So I think we got just over 18 minutes until our next talk. Why don't we just dash upstairs? I'll take you into the lab. I'll show you the instruments that we work on, and you can have a quick tour.